Ladies and gentlemen, my name is Mareike Franz, and I may introduce you to my topic, tumor visualization with indocyanine green in laparoscopic and robotic hepatobiliary surgery. We collected perioperative data of patients who underwent laparoscopic or robotic liver resections because of tumors or resections of solitary peritoneal HCC metastasis from January 2018 till September 2020. We injected ICG intravenously, body weight adapted, and the time of injection depended on the individual liver function of the patient. So we chose an interval from 2 to 14 days prior to surgery for injection. Here we can see the mechanism of tumor fluorescence with ICG. We see a healthy hepatocyte on the right side and a tumor cell on the left side. ICG in green is bound to lipoproteins and is uptaken into the cells by transport proteins. The mechanism of excretion into the bile is disturbed in the tumor cell, so a retention of ICG in the tumor cell results. When radiated by near-infrared light, we can detect a fluorescence signal. Here we see a few examples for tumor fluorescence. This is the case of a patient with an HCC in cirrhotic liver, and we see a homogeneous liver fluorescence signal. These are the classical fluorescence signals for colorectal metastasis. We call it Rimtype fluorescence, and the reason is that not the metastasis itself, but the surrounding area of immature hepatocytes has an impaired excretion function for ICG. This is the case of a patient with an intrahepatic CCC and also an indirect fluorescence, because not the tumor itself, but the area of cholestasis around the tumor fluorescence. We collected data of 7 laparoscopic and 16 robotic assisted surgery for tumor fluorescence, and the distribution of tumors we used ICG for, you can see in the image on the right. We used it in 48% of the cases for HCCs, in 13% for CCCs, 17% colorectal metastasis, 4% adenoma, 9% hemangioma, and also 9% for solitary peritoneal HCC metastasis. The use of ICG led us into a changing of our therapeutic strategy in 23% of the cases. In 100%, we saw a fluorescent signal of the tumors. No adverse reactions occurred in our patient collective by the use of ICG. We saw unspecific fluorescence signals in up to 39% of the cases, either solitary, for example, in von Meyenburg complexes, or as you can see in image 1 and 2, diffuse, for example, in cirrhotic liver with impaired liver function. Image 3 and 4 show the case of a patient with 2 solitary peritoneal HCC metastases. Image 3 shows the strong fluorescent signal of the metastasis, whereas you can hardly differentiate the metastasis from the surrounding tissue in image 4. In conclusion, we can say that ICG staining for tumor detection is simple and useful, especially in minimally invasive liver surgery. It may enhance surgical precision and improve the oncological quality for the patient. False positive detection rates can be reduced by respecting the tumor entity and liver functional impairments. Thank you.